Our objectives today are first to describe our current understanding of promoting patient access to the medical record on quality of care. And that's our main objective and where we'll spend most of our time today. I'll spend a little time describing patient access to the medical record in the context of current definitions of personal health records, electronic health records, and electronic medical records. So that's going to be important in terms of understanding policy-related decisions that surround sharing medical records with patients. But first, I'd like to start with a personal story about how I got interested in this work. Way back 20 years ago now almost, when I was a medical student here at the University of Washington, I was taught to keep the patient first. So in my role as a physician, I was coached to be an advisor to the patient and a collaborator to the patient and an advocate to put patients' needs and preferences first. But when I got out into the real world, I found that was happening much less often than I wanted. Too often I ran into situations like this gentleman runs into when he comes in for his doctor's appointment. Your appointment with the doctor is at 11:15, but his appointment with you is at 12:15. So not very patient-centered experiences. And nowhere for me was this more apparent than in patients who had chronic conditions. It came home to me when I was practicing in Montana in a rural setting, which I really loved, but I really felt like patients weren't getting the care that they deserved. One patient I remember I saw in December on a busy practice day. I'd admitted somebody earlier in the day for myocardial infarction, and I was running about a half an hour late. And I caught up with my nurse and I said, "So Joan, who's up next?" And Joan said, "Well, Mr. Jones is here for his follow-up blood pressure check. He's just driven in 60 miles from his home, and he's waiting in with his wife." So I said, "Okay." So I go over to Mr. Jones. As I walk in the room, I look outside the window of the exam room, and the snow is blowing sideways, and there's 12 inches of snow on the ground. And it struck me at that moment that the blood pressure that I was going to take for that patient today in the office was not nearly as valuable if he had taken blood pressures over the past week at home and called them into me, and we made a clinical decision that way. Not only that, is he'd driven 60 miles with his wife over snowy and icy roads, and now I was going to go in, do his blood pressure check in 5 minutes, and send him home. So the whole incentive for doing that, though, is that that's the only way docs could be reimbursed, is if they saw the patient in person. So in the end, I really felt like this was really unfair at best for Mr. Jones, and probably was not good quality of care for him. What I realized when I started looking into it further, though, is that it's not just the reimbursement model. There's really a larger system failure in chronic care. We know that fewer than half of the U.S. patients with hypertension, depression, diabetes, and asthma are receiving appropriate treatment. And we know that when patients leave our offices, they comprehend as little as half of what we talk about in the outpatient visit as the plan of care. There's also this rapid increase in chronic disease and prevalence and complexity, a sort of big wave of chronic illness and its complexity, and that chronic conditions account for most of the healthcare dollar. So when we look at it, we realize the healthcare system has really been designed for acute care needs that were the primary challenge of the healthcare system decades ago. So trauma, infection, things that patients had, that they came in to see you, the physician told you what to do, you went home, did them, and you were fine, and you went on your way. In today's environment, we have people living with chronic conditions where they need a much different kind of interaction, more collaborative with the provider, more empowering for the patient so they can better enable themselves to care for their chronic conditions in their daily lives. So I really asked myself, is there a better way to care for patients? And there were a couple studies in the late 1980s that made me realize that sharing records can be a really critical part of changing our healthcare system to better care for patients with chronic conditions. These were 3 trials done by Sheldon Greenfield and Sherry Kaplan, and they did it in patients with hypertension, diabetes, and peptic ulcer disease. And they took in these 3 randomized trials, a nurse took patients and coached them to be more proactive in their interactions with docs. And they did this by going through the patient's record with them. So went through the record, identified issues, coached the patient about how to talk with the doctor about questions related to their conditions, and then they handed them a copy of their record. That's all they did. No drugs, nothing else. In patients with type 2 diabetes, they dropped their hemoglobin A1C 1.5 points compared to the control group. And remarkably, these patients had fewer functional limitations. So they were more functional just based upon this coaching and interaction around the record that enabled patients to feel more empowered in their care and their relationships with their docs. Same thing in peptic ulcer disease. And then the folks with hypertension, they dropped their diastolic blood pressure. So those studies, along with a whole other bunch of studies that looked to try to improve chronic illness care, were brought together by Ed Wagner to develop the chronic care model. And the chronic care model has sought to pull the evidence together on trying to improve chronic illness care in the United States to give us a roadmap for improvement. And so the kind of fundamental thesis is you can't do one thing to improve chronic care. You really need to target multiple things. So moving kind of right to left in this group, Wagner's model says to improve chronic care, you need to have clinical information systems that allow you to gather together the patient data that you need to be able to reach out to patients and capture them. So in diabetes, you need to be able to collect hemoglobin A1Cs in a format that allows you to go through your patient list, identify those people who need better glycemic control, and reach out to them. You need to change delivery system design. Get that up there. So delivery system design, that means you got to move away from all of care being focused just on that visit between a patient and a doctor in a room that happens for 10 or 20 minutes. Usually this means bringing in a pharmacist, a nurse, or some other provider to help extend the model of care so that you can more actively meet those patients' needs. You need decision support for both the patient and the doc to make good collaborative decisions for care. And finally, within the health system, you need better self-management support. So that's providing patients with the skills and the confidence to be able to manage their condition, since most of these folks with chronic conditions are making the decisions in their own daily lives that affect their health and well-being. And finally, connecting with the community for resources that can better enable patients to take care of themselves. So community centers or other places where patients can get help with their chronic conditions. All those things, if you target all those things, they lead to more productive interactions between informed patients and proactive practice teams. So we have a nice roadmap in some sense for the chronic illness care model. And that on the heels of that model came this, which is Crossing the Quality Chasm from the Institute of Medicine. This also highlighted many of the structural flaws in the United States healthcare system for improving care for everyone, including those with chronic illness. What's remarkable about the Quality Chasm report is it took a completely different approach to care. And amongst those things that it highlighted was a different approach to health information. So it described the current approach to health information as one in which the patient visit is the organizing principle, and the record is an artifact of that patient visit. And it proposed a new rule, that health information is interactive and real-time and prospective, and holds that information is key to the patient-clinician relationship. So very different vision. The word record is completely gone, and it has this idea of information being collaborative between a patient and a doc, interactive, prospective over time, not focused on the clinic visit. So you're hearing echoes back of the work that Sheldon Greenfield and Sherry Kaplan did about the information in the record being something different in the patient-physician relationship when it's shared, and the chronic care model where you're moving away from these brief office-based visits into more proactive and interaction over time. So, great, we got this roadmap to improve chronic illness care, and we got this other roadmap from the Institute of Medicine about how to improve the United States healthcare system, which looks like it includes sharing records with patients in a meaningful way and changing the organization of care around that. But what do patients want? Do they want to have shared records? Well, Jeanette Foles asked folks in Minnesota, in a study done in Minnesota, would they be interested in reading their record? and she found 36% were very interested, and up to about 70% had some interest. The Markle Foundation went a step further and said, not only are you interested in the reading of the record, but we also want to know if you're interested in services tied to the record. So how interested are you in having a record service that allows you to check and refill prescriptions, get medical tests results over the internet, check for mistakes in the medical record, and exchange secure and private email with your doc? And they found 60% of Americans in 2005 endorsed this view. But what do docs think? Docs are scared. Steve Ross did a survey of patients and docs asking them about their expectations of shared medical records online. Found that the percentage of patients thought, 86% of patients thought that reading the medical record and having access to it would improve their understanding of medical conditions, whereas only 40% of docs felt the same way. And down at the bottom of this chart, you can see 26% of patients thought it would increase their worry, whereas 81% of physicians thought it would. So you got this discord between patients and docs. You got patients on the one side think it's a good idea. You got docs on the other side thinking, I don't think this is so good. I think this is going to hurt patients. Well, meanwhile, several institutions around the country began innovating. Palo Alto Medical Foundation, Beth Israel, and Partners Healthcare in Boston started their own little competitive program about reaching out to patients online with medical records. Geisinger in Pennsylvania, Dartmouth-Hitchcock, Group Health Cooperative here in Seattle, Kaiser, and here at the University of Washington. They began innovating in ways that allowed them to reach out and try to meet that patient need and preference for access to their information online. These are the predominant services that these organizations, which are the main organizations that are sharing records online around the country, are providing. Viewing medical test results, requesting prescription refills, exchanging secure messages with providers, viewing lists of medications, allergies, immunizations, reminders of care, and requesting appointments, and viewing summaries of office visits. So these are not input by patients. These are pulled right out of the electronic record and viewable by patients online. The one piece that's still missing are clinician notes. So none of the big organizations that are sharing these records with patients overall are actively sharing clinician notes with patients. The only place that I know that's doing that to any extent is here at the University of Washington, where we have a few trials and pilots where we're doing that. So now, that's kind of the spectrum of that's kind of landscape right now. I want to talk a little bit about what do we know so far about sharing these records online with quality. And to do that, you kind of need a framework for what is quality of care. CASM report helped us define that better, I think, than anyone else. And they really said quality of care is more than just, are you getting health outcomes? It's also about the experience of care and other issues. And they defined it as 6 quality aims that we're shooting for. Is care patient-centered? Is it timely, effective, safe, efficient, and equitable? I'm going to walk through each of these and the data that we have around shared records that targets each of these. I've got to tell you, we don't have a lot of data. We do have some, and I think it really lays out where we need to go with the next phase of research. So I'm going to start with the first 2. Is it patient-centered? So patient-centered care is care that is respectful and responsible to individual patient preferences, needs, and values, and ensures that those patient values guide all clinical decisions. Is it timely? Does it reduce waits and sometimes harmful delays for both those who receive and those who give care? So timeliness and patient-centeredness have been measured now in standard office encounters by organizations like AHRQ, who've developed the community assessment of health plans. We do not have similar metrics yet for patients' experience with online records and communicating with their providers online. What we do have is adoption, use, and satisfaction. And adoption is quite strong in those organizations who have made it a priority. This is the adoption of My Group Health's online shared record with patients. The line shows the percent of adult members between September 2002 and November 2005 who have started using the record. As of October 2009, we have 57% of our adult population online able to engage in the secure medical record. Kaiser is now up to 27%, They've had about a 3-year lag behind us, or behind group health, in getting this up and going. But their adoption curve is about the same. They have 2.4 million members now across the United States that are accessing the record online and using those services I talked about earlier. So what are people using? This graph shows on the y-axis unique monthly users per 1,000 members at Group Health Cooperative up till 2005, with x-axis being the time. We broke it down into 2 groups. There's the solid line, which shows the most commonly used services at the greatest adoption rate, and then the less commonly used services in the dotted lines. So the most commonly used services, right up there, medical test results. It's the top hitter. Medication refill requests, after-visit summaries, and secure messaging with encounters. So those are the kinds of things that patients and doctors talk about all the time when they collaborate on care, particularly for chronic conditions. Less commonly you can see used are lists of medical conditions, immunizations, allergies, and appointment requests. So more passive information, used less and adopted less strongly. Kaiser has very similar data published this year in Health Affairs, and in that, the use of medical test results dwarfs all of the other services available to patients. Satisfaction largely echoes the adoption. This shows 2004 satisfaction data from group health members based on a 46% response rate of a survey. So some potential for selection bias or response bias in this group, but overall you can see pretty strong satisfaction. In the medication refill on the left side, the more solid bar is the percent very satisfied, followed by those who are satisfied. Secure messaging and test results follow after that. So you can see strong satisfaction in those services that were most commonly used in the prior slide. So how do you share medical test results? Well, you need some kind of nomenclature to figure out how to do this in patients' best interests. So Group Health came up with this nomenclature in 2005, which they submitted to HL7, the standards organization, as one that other providers could adopt. And it places all medical test results into 5 categories based on their balance between overwhelming benefit and negligible harm for sharing. So in category 1, overwhelming benefit of sharing, negligible potential harm. We share all those results, regardless of value, in real time with the patient. So as soon as the doc sees them, the patient sees them. So those are things like hemoglobin A1C or ProTimes for anticoagulation monitoring. On the other end of the scale, you've got category 5. So this is potential for significant harm from early sharing. So this is the bad news that you've got to communicate to the patient, usually in an in-person encounter. So you don't share any of those automatically. Providers manually release those, usually to patients after they've had the conversation with them, and release those results. Those are test results like HIV ELISAs, all pathology and imaging results. So this is one framework for doing this, and I think right now it's still an ongoing conversation about what is the best way to do this, and how does this fit into good processes that you have in your own institution for results reporting to patients. But it gives you a framework for kind of understanding about how you might want to do it. So the question is, also, now who is using these services? A lot of people think it's the guy at home at night sitting on his laptop, like this guy who is in this domestic situation and says, okay, step away from the laptop and hold up your end of the conversation. So I'm commonly in this situation, fortunately, minus the gun. But I think a lot of people think, well, this is the people that are going to be online. So I want you to think, who do you think these people are that are online engaging in online shared records? It's the woman. So when we've looked at this, the average user is a woman who is between the ages of 48 and 52 and has some ongoing chronic condition. Diabetes, depression, and hypertension are some of the most common ones that we have seen. These are also largely the same kind of people that use our healthcare system outside of using online shared records. Oops. So next domain for us in figuring out quality is care effective? Is using shared records effective? That means providing services based on scientific knowledge to those who could benefit and refraining from providing those services to those not likely to benefit. So these are the health outcomes we often think of, health and functional outcomes that we often think of as traditional quality measures. So far, with our data, it looks like shared electronic records appear to be the most effective when they are part of larger interventions to improve chronic care. So interventions kind of like what we saw with the Greenfield and Kaplan studies earlier, or with chronic care model interventions, where you're using the record as part of a larger intervention to engage the patient, meaningfully improving their care. If you just open up the record to patients over the web and you don't really change the processes of care, we don't really have much evidence to support that that leads to more effective outcomes. University of Washington was really a pioneer in these studies that looked at sharing records and effectiveness of care. And Harold Goldberg was the visionary that helped do this. Back in 2000, he decided that he wanted to open up Mindscape, the University of Washington's electronic medical record, as part of an intervention to improve diabetes care. So he set up a program called the Living with Diabetes program that tested web-based support for diabetes care. It used a case manager integrated with a primary care team here at the University of Washington, and he designed it around the chronic care model. So he targeted those 5 domains that we covered earlier. He provided complete access to the electronic medical record. So he just flipped the switch on Mindscape and said, now it's available to patients. Same record docs use. He provided additionally the ability for patients to wire through wired glucometers, send in their blood glucose measurements to their care providers and to view them graphically simultaneously so they could have conversations about them when they're outside the clinic. Provided integrated disease management tools for that and secure electronic mail with their care providers, along with web links for general diabetes education. So a complex intervention for chronic care that included full sharing of the record as kind of as a core part of improving the communication and relationship that patients had with providers. So we ran 2 pilot trials, one in type 2 diabetes, both these randomized trials. And the folks with type 2 diabetes dropped the hemoglobin A1C, which is a measure of glycemic control, 0.7% in the intervention group. And the folks with type 1 diabetes dropped the A1C 0.48%, but did not reach statistical significance. So these 2 trials really helped lay the groundwork for how other studies can help begin to approach using shared records in chronic illness care. Dr. Goldberg also informed this larger study done at Group Health Cooperative of 778 folks with essential hypertension. Very similar model of intervention design based on the chronic care model, but randomization was different in these 2 groups. The first group had a pharmacist case manager integrated with primary care that could engage with patients over the web or over the phone if need be, and exchanged emails with them about their blood pressure. We gave patients a blood pressure monitor to use at home, and as well as access to My Group Health. Group 2 received the blood pressure monitor and the shared record. Group 3 had the shared record in usual care only. So everybody had the shared record, and the other 2 groups had different interventions. So the outcome was blood pressure less than 140 over 90 at 1 year. Well, 1 year, 56% of the pharmacist group, 36% of those with the blood pressure monitor only, and 31% with the usual care had blood pressure under control. So a significant difference. So I think those studies really highlight how you can leverage the record as part of larger chronic care interventions to improve the effectiveness of care. Are shared records safe? Do they avoid injuries to patients from care intended to help them? Short answer is, we don't know yet. Most of our data is still based upon qualitative evaluations. So I think we still need to explore the unintended consequences of sharing these records online with patients. So far, though, it looks like our concerns about patient anxiety are maybe overstated, and that actually not sharing records with patients may cause them more anxiety. So not knowing what's going on in your health that's locked away in that record may cause you more anxiety. We also, I think, need to establish expectations for doctor-patient communication when you're using that shared record. If If you're going to open up secure messaging with patients, if you're going to ask for blood glucose levels or blood pressures, you got to set up expectations with patients about when you're going to view them, how you're going to get back to them. On the patient side, you got to set up expectations that this is not an environment where you can respond to urgent needs. So typically what organizations do at the university when we do trials, or at group health when we sign people up, you have folks go over a user agreement where you run through how you use it appropriately and you establish those expectations. And if you don't, you might end up in a situation like this where husband says, "What do you mean we don't communicate? I sent you an email Monday." Is it efficient? Does it avoid waste, particularly waste of equipment, supplies, ideas, and energy? The short answer is we still don't know, because most all of these online shared records are rolled out not in a randomized way in which we could really rigorously evaluate those. So we really rely on observational studies. What we do know is that visit patterns change when you do this. The Greenfield Clinic in Portland, where they've had several years, patients have had access and are encouraged to use messaging and phone visits. 80% of their encounters are over phone or email. So only 20% of their encounters are in person. At Group Health, we're up to about 25% of encounters through secure messaging, and that's growing. At Partners Healthcare in Boston, about 28 secure messages for every 100-person visits. So if you change the structure of care to encourage these interactions outside of that clinic visit with the provider, you see a radical shift in the pattern of visits. There have also been a couple of studies that suggest that secure messaging may be associated with fewer in-person and telephone contacts, such as the ZOO study in the American Journal of Managed Care. But those are tough studies to do, again, because they're observational studies. And the people that use these systems are different. The patients that use these online records are different than the patients that don't. So trying to understand and control for those in a study environment is hard. Is it equitable? Are shared records online equitable? Do they provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status? Well, we're still sorting this out. I think we're still early in the adoption phase. What we do know is that 2 studies have shown there's widening disparity in use among African Americans compared to whites. That's been shown both in the Northern California population by John Su and in the Georgia population at Kaiser Permanente by Roblin recently this year. We don't know exactly why this is occurring, but we've described it. I think we also need a broader look at the barriers to access, and not just at the patient level, but at the provider level, the organization, and community levels. So community levels are things like broadband access. Organizational levels. So do you have an organization that's encouraging patients and doctors to use these services online? Do you have provider characteristics? Do you have providers that really like this, don't like this? Do you have providers that feel like they can do it? And then on the patient side, we've got all those concerns about health literacy, physical disability, and technical literacy. In the end, though, I think we got to make sure we honor preferences access for care. So you need an organization that doesn't funnel people to online access away from other ways that patients access care. So if you're going to encourage online access, make sure you also give them access other ways. So access to in-person visits or phone visits. Make sure that you're getting patient-centered access for those folks. Otherwise, you may set up a situation where they're seeking online access because they can't get in some other way that might actually fit their needs. I think the other issue with equity is we really have to look at equity in terms of the larger challenges of folks getting any access to care. So to use shared records, for the most part, you already need health care coverage. So you have to look at access to these records in the larger context of the overall challenge of providing access to everyone. It's like this woman and this doctor have the experience of, you can rest assured, Mrs. Wilson, that your husband will receive the best care known to medical coverage. So I'm going to switch gears and I want to talk about how shared records fit into some proposed definitions on the electronic medical record, the electronic health record, and the personal health record. So I'm sure you've already heard many definitions for these different terms, or a few of you had. These definitions I'm going to review today came from the Department of Health and Human Services April 2008 document on defining key terms for health information technology. So this is the conversation I think that's worth listening to, because this will define meaningful use. And meaningful use will be tied to dollars for providers to be incented to use electronic health records. So in this world, electronic medical records mean individual data created, gathered, and managed, consulted by authorized clinicians within one healthcare organization. So that's the University of Washington, Virginia Mason, Group Health, Mayo Clinic. Electronic health records conform to nationally recognized interoperability standards and can be created, managed, and consulted by authorized clinicians across more than one healthcare organization. So raise your hand if anybody knows of one of these that exists. I don't think anybody yet knows. So the electronic health record definition is the one that I think the vendors are particularly looking out for, because the vendors who make electronic medical records are trying to figure out how they might conform to such a standard. Personal health records also conform to a nationally recognized standard of interoperability and can be drawn from multiple sources, but are managed, shared, and controlled by the individual. So the key here is that the patient controls personal health records. So unlike provider organizations that are really stewards and controllers, largely controllers of electronic medical records, personal health records are controlled by patients. Where does shared records fit into that? Well, right now, shared online records largely are extensions of the electronic medical record. So when I go online and communicate with the patient, I am doing that in an environment that is governed and regulated under the federal law that allows privacy and security of that record. The Health Insurance Portability and, Health Insurance Portability and Privacy Act. So that ensures that that record is secure and private between me and the patient. So we're writing the record together, so the patient has some control over what's in that record, but really it's stewarded by one healthcare organization. So right now, shared records are really part of the electronic medical record. Nobody's really figured out how to pull personal health records into that conversation. Personal health records have this challenge that they are controlled and managed by the patient. And right now, the vendors that are providing those are really outside of the healthcare system. So Health Vault, Microsoft, and Google Health, they're outside the healthcare system. They are not covered entities under HIPAA law. So they don't have the same kind of requirements for privacy and security of those records. So there's no good way yet to marry those two. Keep your eyes out, I am. Why is all this? Why is all that language important? Well, if you look at the June draft of meaningful use for electronic health records, which we anticipate will drive incentives for federal stimulus of electronic health records, it includes shared records. So 2011 measures proposed include the percent of all patients with access to personal health information electronically, including lab results, problem lists, medication list, and allergies, and the percent of encounters for which clinical summaries were provided. 2013 measures include the percent of patients with access to secure messaging. So right now, it looks like the conversation's just sidestepping the whole personal health record question, and they're going right now to sharing records with patients as part of a definition of electronic health records. But I know there's a lot of conversations about this on the Hill because there's advocacy groups from both sides that are trying to figure out whether this is really what they want in that overall stimulus package. Next steps for shared records, I think we clearly need further research on quality. We've just begun. We're still in that adoption phase amongst those innovator organizations. So we're still pretty early in the quality world. Adoption is, as often happens, faster than we have research on really how to do it well. Organizations like HRQ at the federal government are providing more and more opportunities for us to study quality, and so I hope we can catch up on that. I think we also will be looking for how this conversation between the personal health record and the electronic health record come together. How will we marry patient control with what's been traditionally a provider-controlled record, and how will policy decisions support that? Mobile shared records. So more and more people, particularly our younger population, is using mobile devices as a primary communication tool. How are we going to provide these services meaningful to patients on mobile devices. We started some of that work here at the University of Washington on a couple of grants from the Johnson Foundation to extend the project I described earlier with Dr. Goldberg. With diabetes, we've extended that onto a mobile platform, so we're exploring that. And there are some real challenges in the mobile environment to making it valuable for patients. And I think we'll be addressing those hopefully in the next 10 years. Finally, access to Clinician Notes, which has traditionally been pretty taboo for any large healthcare organization. University of Washington is a leader in this, and has been for the last 10 years. It's remarkable how elsewhere in the country people are scared of this. Fortunately, we've teamed up with Tom Delbanco from Harvard and Beth Israel, as well as Geising in rural Pennsylvania, to do a study that shares primary care provider notes online, and to do it with a lot of people. So we're trying to recruit 30,000 people, 100 providers at these 3 sites. And at the University of Washington, we picked Harborview, which is a particularly interesting population to study because it's largely underserved. And we're looking at patient and provider expectations and experiences with sharing those primary care provider notes online. So through all of this, though, I would really hope that we can keep patients first. I mean, so often when we design healthcare and healthcare systems, there's other interests that come into the conversation. Online shared records are a great opportunity for us to really ally with the patient and make that patient first. So to finish, I want to share with you a final quote from Bob, a 61-year-old gentleman who was in study here at the University of Washington several years ago, and he describes his experience with our program this way. I feel much safer now than I did before. If I had to pick one thing out of how this program has affected my life and my everyday living, it's the fact that I'm not chronically worrying about everything. If I didn't have any access to knowing what's going on in my health, I think I'd probably go back on ulcer medicine. Thank you very much. Questions, yeah?
Question, there's one particularly common error in laboratory testing is failure to follow up on a lab test. So, the patient never gets their result. So it seems to me that patients who have access to electronic medical records, this really solves their problem. Has that ever been formally studied?
It's not been formally studied, and I think it's a great study. This problem I know was highlighted recently. I think it was in a paper in the archives where I think it was
7% or something did not get something like that.
They never got followed up, right?
Right. It's
a
few percent in any study I've ever seen.
It's a big problem. I don't think sharing online lab test results should solve that issue. I think organizations need to build in good processes for sharing lab test results with patients, and I think that's what that really highlights. Sharing them online with patients, I think, should be part of that process. As a doc, I love having my patients have access to their online test results.
Because it's like a backstop for you, just in case something went wrong, and then they can educate themselves and things.
No, it actually, well, it helps me because we already have a good process for informing patients.
Right.
And as part of that process, I know that the patient expects to get the result. Whereas when I used to practice, it often felt like the providers were and the patients were in the no news is good news realm. So if the patient doesn't get the result, then you just assume it's fine. And we know that's not the case. So having the patient online, expecting to see that result, me knowing that, actually I feel like is a great piece of that larger process. But it really points out, I think, that we need good process of care to make sure that we're getting those results to patients, whether it's online or offline. Yeah.
I am a group health member, and so I've looked at my medical records, and I have very few. I've only had a few lab tests, but I could imagine someone who's had a serious illness might have been in an ICU for a while and have hundreds or thousands of lab results there. Is that something that's posed a problem for someone to navigate through an incredibly large morass of, 27 days worth of, blood gases and things like that?
Yeah. So, well, I think it is a challenge for some people with the patient user interface that we've got, and I think we need to find creative ways to address those challenges. Right now, the most recent lab tests pop up, so patients can see those, and depending on your system, they can also graph those. But for my most complicated patients, which are the ones I usually see in clinic as an internist, they do actually they'd rather see my results reporting than the ones they see in my group health. They say, oh yeah, I like yours better because you can see all those things in so many different views. So I think it's more of a challenge, it's a design challenge for us, but it's an important one.
So I know your patients are expressing satisfaction with email exchanges. The providers themselves, do they feel that they spend less time or more time than the equivalent phone call? And how's that working out?
It's a great question. In general, docs that are given the space to do this like this. If you add this on to expectations for in-person productivity, it frustrates docs. Jim Tofano here at the University of Washington studied this in the group health providers before and after we changed those incentives for secure messaging. So before we had expectations for productivity incentives for in-person visits. We didn't really allow providers enough space for messaging as it was beginning to grow. And they got frustrated because they really wanted to be able to do it, and they knew their patients wanted to be able to do it, but they felt like they couldn't fit it in. When we switched that into a medical home environment where we created a much greater team structure to support the doc and gave the doc more time to be able to message patients and have open phone visits, then those visits expanded. Those phone visits and messaging encounters and visits expanded, and docs were happier when we surveyed them. So it brings up this important point that you got to design the care system to be able to support that. And right now, most of the world operating in the environment where you're only paid when you see the patient is really challenged to do that. So you have to set up something like Palo Alto does with their medical foundation, or that Greenfield does, where they charge patients an extra couple $100 a year so that they can have email access or phone visits, and that's on top of their insurance plan. There's not yet a great solution, I think, for the majority of Americans.
Does group health or any other organization providing these kind of services have a way of providing interpretive information with labs directed at the patient, either a sort of a non-jargon laden interpretive comment for each test, or some way of summarizing a batch of tests? It seems like we have enough problem communicating results to clinicians, let alone patients who might be trying to interpret a panel of labs.
Yeah, it's a good question. I think the big answer, I think, is that sharing online labs with patients does not substitute for good patient-physician communication. If you're ordering a lab test for a patient, you're responsible for informing the patient about why you're ordering that test, and when that test comes back, you're responsible for educating them about what that test means. So that's that's the big picture. Separate from that, most of the big organizations like Group Health or Kaiser do tie explanations of these test results on. So when you get a test result in Group Health, you have an XML link, a hyperlink, that takes you out to the HealthWise knowledge base, which describes in patient terms what that test means. And then if you don't understand a term, then you can click the hyperlink further in HealthWise to try to describe that. And that, I think, just from anecdotally, that works for a lot of people, but I still have patients that come in and want to talk about what that result really means. Yeah, in the back there.
You showed several studies that showed that there was an improvement in the quality of care, like the lowering of A1C, for example. So it seems intuitively this in some cases, it should lower the cost of care. I mean, if you can have essentially a more efficient process. Are there any studies that have kind of looked at that? Or
yeah, does it lower the cost? And secondarily, is it cost effective? No, is the short answer to that question. I'm not seeing any. There are some messaging studies that have looked at small trials of. Eric Lederman did a small study at University of California, Davis, that looked at how does messaging impact provider volume and billing, and showed that messaging actually enables providers to probably bill at a higher level because they can see, when they see patients, they know what's going on, and they can do more intensive visits and thus bill for that. Small study, I'm not sure that's very generalizable. The zoo study from Kaiser did show there was some substitution effect, but I don't recall that she had any costs associated with that. The effectiveness trials that you're referring to, those are complex interventions in which we changed the care design of the team, and so we engaged new people in that team. In the case here at the University of Washington, it was usually nurse practitioners or nurses, and at Group Health it was pharmacists. So you have to account for the costs of changing the team structure. So far we've not shown that it's been cost saving or cost effective. We're working on the cost effectiveness piece of that Group Health study now, though, so I think a lot of people are going to be watching for that, though, in these larger trials. Yeah.
One of the kind of reservations that I would think about patients reading clinic notes is that they're just sort of peppered with acronyms, at least they are here, you know, and jargon, and I guess it's sort of a two-part question. One would be, is there any research that physicians are actually sort of making their notes more intelligible to a patient population as a result of them being accessible? And two, do you think that that's really a problem, that patients might actually get, you know, you might actually miscommunicate something by a patient reading something and not really understanding, or maybe Googling an acronym and getting something different than what was intended in the note and then acting on that or something like that?
Right, yeah, I think those are great questions, and I think that's the reason we're studying them. And we're also limiting it to primary care notes so that it's set up in a continuity relationship with the doc. Nobody really knows the answer to that question. The most experience in the world with this is here at the University of Washington at our primary care clinic. And those docs, by and large, don't have any problem. And the patients so far like it. And when they do say sometimes, I don't understand what's in the note, but I like having access to it, and I like just knowing that my doctor knows me. So I think there may be some value in just the act of transparency. Not so much that they understand the content, but the act of transparency that's important. What I hope is that when patients and docs start opening up these notes together, that it facilitates a better conversation around what's going on in the physician's thinking and what the care plan is. And that may actually help the patient engage more in the relationship and in their care and benefit from that. But that's part of why we want to study this on a much larger scale and talk to docs and patients about its impact, the same kind of impacts you talked about. Yeah, way in the back there.
Has there been any experience with, quote, problem patients, that is, patients with drug abuse or Munchausen syndrome, those for whom would wonder at least whether access to the record would actually impair the ability to take care of the patient?
You know, there's not in the last few years. Back in the 80s and 70s, there were a variety of docs that experimented with sharing paper records with patients and sharing mental health records with patients. And there were some challenges with that in those populations. But they're small studies, not really powered to detect anything, so it was mostly anecdotal. I've not seen reports about that in these organizations that are sharing everything but the clinic notes with patients. And the studies so far that are sharing clinic notes are pretty small. So, you know, I think there's good questions. I think we do need to be careful about using the exceptions to make the rule, I think, about how we decide to share. Yeah.
So in the data that you show where the patient status is improving, is there any way, do you have the ability to tell if that is because you have patients who have access to the records more in depth and so they're becoming more intelligent and more sort of involved in their own medical care, and can you separate that from, you know, just increased accountability to the doctors and sort of, you know, knowing that their patients are looking at these records and knowing, you know, that there's going to be more involvement, just sort of increasing their care in that way, and it really has nothing to do with on the patient side, but more on the doctor side. Can you separate that?
You know, what's in the black box of those interventions? I think it's a good question. I don't think we know the answer to that. when you talk to people and to docs, it's mostly on the patient side that I've heard it when I've talked to them in the qualitative results, like the ones I presented from the British Medical Journal, that it's the patients who feel like I'm being cared for, I got somebody looking over my shoulder now, I feel like I can get the confidence and security to engage in my care. When we've begun to look at the processes behind what is leading to those better outcomes, in patients with diabetes, we have some results that suggest that it's how much they submit their blood glucoses and exchange messages with docs, and that leads to adjustments in medications. So there may be, behind the idea that I feel confident and empowered, maybe this communication that's becoming more intense, and we've opened up meeting that need. So far, not heard from that it's providers feeling more accountable. With the Open Notes project, where we're actually sharing clinic notes with it, that may change as providers think more about, man, my patients are going to be reading my notes. I want to make sure I got the care plan down and legible.